now that we've all got used to it. I mean, who knew what Zoom was 3 months ago? I certainly didn't. And listen, if my mum can figure it out, then trust me, anyone can. My window cleaner has just chosen this very moment to come and clean all the windows. So if you hear any rattling and banging about, not off-putting at all, my window cleaner staring at me during this. So I apologise in advance. So part 2 is called Push, Don't Brush, and you'll see where that title comes from a little further on in the presentation. This is my favourite part of every appointment. I just love giving oral hygiene instruction. I love debating it with patients and delivering it, and I have no idea where the anecdotes come from sometimes, but they're often hilarious, sometimes questionable, but always hilarious. But that doesn't matter, because I just think happy, motivated, enthusiastic clinician can't help but bring out the motivation in a patient, and that's what it's all about for me. I had an overwhelming response to part 1, and Sharon was just giving me the up on some of the feedback that she got, and so I just want to thank those that got in touch afterwards, both on the forums and via email, because it really was very heartwarming, and it made me realise just how much people are struggling out there, and that in turn motivated me. So you see, we all helped each other, and I've had some brilliant and frankly hilarious pictures of the calculus boxes that you've all been making since last time. Some of the messages on the front of the boxes were quite simply unrepeatable, but hilarious nonetheless. They have kept me laughing ever since. I hope you bosses understand. It was very funny, so please keep those coming. And also, I just want to add that I'm going to leave my email address at the top of each slide today, because poor Sharon from BSDHT got lots of emails with various requests after part 1. And although I'm sure she doesn't mind forwarding them on to me, I hope this way will just save her a little bit of time. So if you've got anything you want to get in touch with me about, then feel free to email me directly. I'm all about love and support for each other. So anything that I can do, just holler. I had lots of requests for the perio and the gingivitis sheets and the OH sheets after last time, which I'm more than happy to share with anybody. I'm not precious about them at all. So just drop me a line and I'll send you on the PDFs. So once again, I must take a moment to thank BSDHT for inviting me to speak to you today. I'm very happy to be here, and actually for the incredible job that they've done overall in putting this entire programme together for us. And also to Oral B, who without their sponsorship, I said this last time, this programme may well not have gone ahead at all, and certainly wouldn't have come to us for free. So thank you to both. The webinars, I think, have just been brilliant. They're not over yet. There's a couple more to go, so look out for those. But I hope that those behind the scenes are feeling accomplished and proud of what they've achieved and what they've managed to do for the members during this time. I hope they all know just how grateful we all are. For those of you that didn't tune in last time, this is me, all you really need to know is that I'm a practicing hygienist up here in North Yorkshire, but also that I did some further education in counselling skills and behavioural therapy. As I said last time, I believe wholeheartedly that our job is not to treat teeth, our job is to treat people with teeth. And once you switch to managing the person rather than managing the condition, then the rest is a bit of a walk in the park, she says. Honestly, my patients make me look like a fantastic hygienist, but honestly, it's not me that gets those results, it's them. That said, I'm very happy for my boss to think that it's me, especially when it comes around to peer review time. So let's keep that secret between us. So that's what I'm doing here today, and we're going to pick up where we left off last time, delving a little bit further into how we communicate with our patients when taking a prevention-based approach. So hopefully you did all join me last time, and if you didn't, then hopefully you listened to the recording afterwards. If not, then I strongly recommend that you do, because as I said last time, there are two parts to successfully changing the way that patients engage and how well and how successful that is, which is why this webinar is divided into two. Also because I talk too much. So the first part to motivating a patient is helping them to understand why they need to do what they need to do. We can't just tell them that they have to do it for their gum health. That's just white noise. We have to open their filters so that their desire for change and improvement comes from within them. If you do the groundwork and you get this bit right, then the second part, which is today's webinar, which is actually the delivery of instruction, is much better received by the patient, because they actually want to hear it. They want to hear that information, and not only that, but it's also better remembered. Because the patient's listening properly. Without investing that time and effort into part one, then part two will rarely achieve the success that we're hoping for. So the aim of today is to have a look very briefly at the different oral hygiene aids we need to consider in clinic. I'm going to stick to the main groups because I would be here till Christmas if I started trying to list and demonstrate every OH aid on the market. So I'll keep it sensible. If anybody wants to ask me about a specific aid, then feel free, pop it in the questions box and I'll do my best to answer it at the end if we have time. We'll very briefly discuss the science behind the use of different aids, but only very differently, because that's not what today's about. What I want to spend more time on today is looking at the actual technique that we teach and how we deliver that information so that the patient receives it and understands it, and can then replicate it at home. Stick with me on this. Some of the tips for the OH techniques, especially when we get to toothbrushing, might surprise you. I know that because I've delivered this lecture a couple of times now in various places in the country. So I know it's something that we're not all on the same page with. And then we'll also have a brief chat at the end about safely delivering OHI when we return to work post-lockdown. And where I'm at on that subject. I think you can probably all guess what I'm going to say and where I'm at. A day without OHI for me is a day wasted. But I know this is something that's open to debate at the moment. So we'll have a little look. We'll have a little look at that at the end. I've got my feel-good pants on yet again, my feel-good hair, and I'm raring to change the world. So here we go. I'm not going to repeat myself too much, but I have to say this. I said it before, I'm going to say it again. I'll probably say it 10 times throughout the appointment. The winds of change are blowing, and now is our time. It's our time to show our patients and the world of dentistry what we're made of. Instrumentation, regardless of whether it's hand or ultrasonic, is only a very small part of what we do, and therefore it should be forming only a very small part of every appointment. There's so much more that we do for our patients and for our practices that we work in, and I'm all about focusing on long-term results and not short-term improvements. And if we're feeling motivated and we get part one right, then the patients will focus. Patients' focus will also shift, and the practice will have to shift with us, whether they like it or not. Remember, we're highly trained professionals. We're trained to prevent, to treat, to protect, to educate, to motivate, to inspire. And I, for one, will leave this profession before I stop doing that. I don't care what instruments the regulations say I can or can't use. My ethos, my approach, my passion, my determination will remain as focused on prevention as it ever was. We will make decisions based on what we deem is in our patients' best interests, and we will dictate what needs doing. We're there to manage and prevent disease, and that's exactly what we're going to do, altered scope or no altered scope. We owe it to our patients, we owe it to our profession, and we owe it to ourselves to get this to get this right and to make these changes. No more mixed messages or misplaced information, no more focusing on calculus and scaling teeth. This is non-surgical prevention-based therapy. Our focus is prevention. Our approach is dictated by us. Otherwise, we'll be like these guys in the picture until we retire. Scaling machines forever, too busy to consider change. Well, not this hygienist, my friends, and not today. You picked the wrong girl. The time for our revolution is now, and the time to rewrite the rule book is now. So let's remind ourselves about this statement, because you know it's my favorite, and I can't get through a webinar without quoting it because it's so important. It has rock solid evidence to support it. There is no argument against it. It's not about our skills, it's about the patient's skills. Our job is to refine their skills, not to showcase our own. And anyone who tries to tell you otherwise is quite simply wrong. So do not accept being told that you didn't spend long enough cleaning or scaling by anyone. Do what's in your patient's best interest. They don't necessarily know what that is, but you know what that is, and I know what that is. So let's stop with the 50 shades of I haven't got enough time or whatever else it is and focus. I said it last time, I want this statement engraving on my headstone. I hope you've all been thinking of places where it can be displayed in your practices. Say it again and again and again, and don't stop saying it. Say it to patients, say it to colleagues, say it to family, say it to yourselves. The most important factor in the prevention and treatment of periodontal disease is the individual's standard of self-performed oral hygiene. Switch the focus from your efforts to the patient's efforts, from clinician-centered to patient-centered, and let's see, let's show everyone what we're really made of. Our time is now. We have the power to change the periodontal health of the nation, so let's get on with it. So you'll hopefully remember our 3 pillars of behaviour change from last time. There are 3 areas to focus on if we're going to get this right. There's the patient, how receptive they are and the type of learner they are. There's the clinician and our delivery and communication skills, which we have to invest in developing, which is exactly what you're doing now. And then there's a physical act of the technology and the tools we use to teach. So we covered the first 2 last time. Let's get rid of patient. We covered clinician last time. So today we're going to focus on the tools that we use and the techniques that patients need to establish to achieve high standards of plaque control. This isn't about pushing one brand or another. It's about getting to know our patients and combining the knowledge that we have about products and the knowledge we have about our patients' ability and willingness. It's about figuring out what's going to work best in their situation, in their hands. And quite honestly, they could use a twig out of the garden if it's the thing that was most efficient at cleaning for them. I couldn't care less. If it works and it achieves the result I'm after, then I'm all ears. Thankfully, I'm yet to meet somebody who successfully uses a twig out of the garden, otherwise I might be eating my words. So today we'll stick with those modalities which are a little more commonplace than garden offcuts. So let's think about this. When it comes to actually teaching a patient how to clean, patients must understand that it's a skill, and it's a tricky one at that. And as such, it needs to be taught. I use the example of swimming, or sometimes learning to drive would be another one. We aren't born knowing how to swim. Most of us are taught as children, but if we're not, then just because we've grown into adults doesn't mean that we automatically know how to swim. We still need to be taught it. Oral hygiene instruction is the same. Swimming itself might be common. I bet half, if not more, of the world's population can do it, but it isn't something that they learned to do without a lesson. So someone had to teach them. They wouldn't be able to just jump in and do it. Those who receive proper lessons probably have better skills than those that were self-taught. Oral hygiene is exactly the same. And also, you have to be shown how to swim. You can't learn just by being told. If you told someone how to swim, or if you told someone how to drive, no matter how well they listened, they'd jump in the water and lightly sink to the bottom, or crash the car on the first turning. They have to be shown, and they have to be taught the techniques, starting with the basics and then building each week as their skills improve. And oral hygiene, in my view, is just the same. So you can't tell a patient how to do something, or even show them how to do something, and expect that they'll return a week later with a perfect technique. Most likely they'll get it maybe half right, maybe 75% right. Some of them nail it, not many. And we'll be saying, you know, you've done a great job, we just need to tweak a little bit, usually lingual on the lower sevens, and so on. So we build up their skill until they've mastered it. We have to prepare the patient for that. If we have them believe that we can show them once and they'll nail it, and then they'll return not having, and then they come back not having got it quite right, and you have to tell them that it needs a bit of work, and they feel instantly like a failure, and their inner child comes out and they want to give up. If you say, I'm going to teach you the basics today, and then next time we'll build from there and work on the more tricky bits, then you can praise the hell out of the fact that they got the basics right. They'll be thrilled that they've qualified to go on to learn next level. That way you keep them focused and you manage their expectations, which keeps them interested. It keeps them feeling competent, which is super, super important in this journey. What I don't do is go wading in and throw in toothbrush instruction and ID aid instruction and whatever else it is all in one visit. It's just too much for patients to master all at once, and we're kind of setting them up for a fail, especially in the big perio cases. You're seeing them multiple times anyway, so you might as well build on this. Remember, different patients learn at different rates. We learned all about that last time. We actually refer in my practice to the oral hygiene stages as lessons where I work. So the dentist might say, I'm concerned about your gum health. There's some things you can do to improve the health and the prognosis. I'm going to refer you for some oral hygiene lessons with Faye. And we emphasize the word lessons, which is always plural. No mention of scaling or polishing or any other of those obstructive words. And sometimes he'll dictate how many lessons. So he'll say, I want you to have 3 lessons with Faye, and then we'll review. Same for smile makeovers or ortho cases. You know, it doesn't have to be big perio cases. You have to have the OH lessons before we can proceed. And it gives a totally different message out, and it places value on that part of what we do. It makes patients see that they almost have to qualify, they have to pass, they have to qualify before they can move on to any kind of active treatment. So you can see how just changing the language from advice to lessons completely changes the dimensions of what the patient hears and what the patient expects to happen. If I have a big perio case, I'll also use those words. So rather than writing on their estimate OH advice times 2 times 3 appointments or whatever it is I think they're going to need, I would write OH lessons. It's the absolute simplest of changes, but really does change the focus, and somehow patients seem to accept paying for a lesson a lot better than they accept paying for advice, which I always find odd, but it's somehow less condescending too, I think. And I tell you what else they do. When you call them lessons, they start booking other people in for them. I've had patients' husbands booked in and kids booked in, and they've rung up and said, I want to have some lessons with Faye. We as a nation, we're just more accepting of lessons for some reason. So I've found this a really effective way of getting that message out there. So oral hygiene aids broadly fall into 5 categories, and not every one of them suited or necessary for every patient. So we've got toothbrushing, ID aids, subgingival brushing, water irrigation, and mouth washing. We're going to focus mainly on the first 3, and I'll go through those one by one. The latter 2, we're only very going to briefly touch on because they're used more sparingly and only in very specific cases, despite the fact that they're probably the 2 that we get asked about the most. That's marketing for you, which is why I've left them in there, because I know they'll come up in the questions at the end if I don't mention them. So before we start with our OHI instruction, we need to get all our ducks in a row, as we say up here in Yorkshire. And that means getting ourselves well organised, ready to teach with no barriers for us, no barriers for our patients, or as few barriers as there can be, so that they're comfortable and they're in a good place, and therefore they're going to be more receptive to learning. If you can, and this might sound a bit woo-woo, but if you can, try to establish your patient's learning type. I touched on this last time. Again, stay with me on this. It can sound a bit complicated and it takes a bit of practice, but if you figure it out, it will really help them to learn, because you'll change your language to suit their learning type. Now, you have to listen to the language that the patients use to work this out. We don't have time to go into it completely in too much detail, but there are 3 learning types. And we all have a little bit of each of them in us, but usually we have one very dominant type. So we're either auditory, visual, or kinesthetic. A visual learner would say things like, oh, I don't like the sound of that, or that sounds awful, that sounds dreadful. A visual learner would say things like, I don't like the look of that, and they're very visual. They'll say things to you like, you look nice today, or look at that when they're walking down the street. And a kinesthetic learner would say things like, I don't like the feel of that. These are the patients that are really receptive to how things feel in their mouth. If you have a very strong auditory learner, then explaining instruction is really important, because they're listening to the words that you're using all the time. If you have a strong visual learner, then using pictures and images and always a mirror can really work quite well. And if you have a very strong kinesthetic learner, then that patient is going to need to feel how those aids feel and in their mouth. I think that one actually is crucial for everybody. We'll get onto this regardless of the learning type, because it helps with confidence if it's demonstrated inside the mouth. I could do a whole webinar on learning types. This stuff I find really fascinating once you get into it. And also it's quite the personal journey too. If you want to try and figure out what type of learner you are and why you respond differently to things, I find it really, really interesting. I am an out and out kinesthetic learner, no surprise there. I'm all about how we make people feel and how they make me feel. I want to hug everybody that I see. I'm very, very hands-on. And I expect many people in our profession are, which is why we do what we do. Anyway, I really want to say so much more about this subject, but I'll run out of time, so I'm going to move on. Just bear it in mind. But we don't all learn in the same way. So in addition, there's a couple of things, very basic, but I find them very helpful. So I thought I'd just give you these few tips before we get on to techniques. Get some cheap reading glasses. You can pick these up in Primark for, I don't know, maybe £2 or £3 each. They're dead cheap. I've got +2, +3, +4, because I got sick of patients letting me go through the whole OHI session and then telling me they couldn't really see what I was doing. So I bought some cheap ones to put on patients if they need them. It's so simple, but it makes all the difference. We have them also in our waiting room, so patients can see the medical history forms properly and they can read the papers if I'm running late. I got the idea from my local curry house, actually, who has a couple of pairs out on every table when we go there, so people can see the menus, and I just thought it was absolutely genius. So I introduced it in my surgery, and voila, no more forgotten readers obstructing my OH lessons. So no excuses there. Remember also to ask patients if they do wear glasses to make sure they put them on at home before they clean their teeth. You'd be amazed how many don't do this when you actually ask them and they tell you that they never considered doing that. Second thing, of course, hand mirror. I would expect everybody to have one of these in the surgery. So that's a hand mirror that lives in your surgery and it's got your name on it. And if needs be, just put an alarm on it so that nobody takes it out of your room. You need this for every single patient. And particularly you'll find your visual learners just can't be taught without it. Also suggest the patient installs a mirror at home that they can actually see in. So not one that their 6'7" husband put up. I always suggest they install one of those round magnifying shaving mirrors. They're really great, aren't they? Either one fixed to the wall, but the standalone ones are just as good. That's what I have at home. And all of these things can help the patient to focus and place importance on their home care, and it eliminates a lot of the excuses that patients come up with too. Turn the radio down when you're doing your OHI. I'm all about music when I work. I'm always singing to my patients. I'm not sure how much they enjoy that, but I do sing to them all the time. But not at this point, not when I'm doing my oral hygiene instruction. Again, especially for your auditory learners, they will really struggle to absorb what you're saying to them if there's lots of background noise behind them. It can be very distracting for some patients, and very difficult for them to take the information in. I'd say this is even more significant now if we're going to be communicating with patients via masks. It's probably even more important not to have that background noise. And also then have a think about your position. So that's the patient's position, but also your positioning. So get them where you can see properly, get yourself where you can see, but get them where they can see. And this will change depending on who you're treating and what stage of the teaching process you're at. So during the early demo stages, nearly always I'd be stood behind the patient with them sitting and watching in the mirror while I reach around and teach them what they need to do. Once I'm at a stage where they're showing me what they've done, which is rarely the first visit, usually I'll teach them and then I'll preempt. I'll say I'm going to ask you to show me next time so that they're prepared for it. So when we get to the stage where they're showing me and I'm modifying their technique rather than teaching a new one, then they might well be standing as though they're at home in the bathroom mirror. They tend to do a bit better that way. It all depends. In one surgery, we actually have a little bathroom sink and a mirror on the wall where I'll ask them to go and stand. And they're generally a bit more comfortable doing that, and not in the early stages, like I say, but certainly when we get to the review stages, because it's much easier for me to pick up on what they're doing wrong, things like their arms in the wrong place, if they're stood up in the position they'd be in if they were at home. Pick up things like poor grip and so on. If I can see what they're actually doing at home, then I can interpret it a little bit better. And this is how much focus and importance we put on this part of the appointment. It's the most important part of what we do. So the more we can do to be able to understand what the patient's doing at home and how we can modify that, then the better the lesson will be. So we have to get ourselves set up right, and they're just a few little tips and tricks and things that I do. You've probably got another list you can add to that. So let's get back to our big five and talk about what are the right techniques and how do we effectively teach them so that the information and the knowledge inside of us is effectively transferred from our heads and our hands over to the patients. I'm going to, like I say, briefly run over the first two because we don't really teach those, but we do have lots of discussion about it. So they've been worth putting in. Hence, we're going to start with mouthwash. Let's not dwell on it. There's very little, if any, evidence to support its use in periodontal treatment. I know I'm preaching to the converted. I know that you know this. Excuse me, I tell my patients that the bacteria calling the shots and that which is most capable of causing the most damage is safely tucked within the biofilm, which acts like a shield, almost like a waterproof bubble, like a bubble around the bacteria, and that bubble or balloon, if you like, is resistant to chemicals. So no amount of throwing mouthwash at it will penetrate more than the very outer surface of the protective bubble. That bubble is, however, physically very, very vulnerable. So if you pop that bubble with the bristle of a brush or an interdental aid or whatever it is, then you disturb the colony inside, and that then messes everything up for them. My patient's job is to go around bursting and popping these microscopic bubbles from underneath their gums. It's not exactly what happens, but it's in the right ballpark, and it's a language that patients understand. It gives them a specific task that feels achievable. Which is also very important. Patients believe that they can pop bubbles. They don't necessarily believe that they can do much else in there. Alternatively, I might just tell them it's like throwing a bucket of water at a dirty car and expecting it to clean it, and that usually stops the masking as well. That said, and the reason I've left this in here is because we don't only treat periodontal patients, do we? And where I do see a place for mouthwash would be in very specific cases where it's required medicinally. So I treat a lot of oral cancer patients with severe mucositis and usually a degree of xerostomia. This is somewhere where I might introduce it. Patients with high caries risk would sometimes might be another category, but not before I was happy that they were doing as much as they could do with a toothbrush. Some special needs cases, and so on. So in short, there's a place for it, but only in a very select few patients group, and certainly not as an adjunct to periodontal cleaning. There just isn't any evidence to support that. Just don't make things more complicated than they need to be, and especially when there's no evidence for it. I also don't like the idea of using chemicals constantly when there's no real need for it. So that's my thoughts on that subject anyway. Similarly, with water irrigators, for me, the jury's still out on this one. I believe the European Workshop states that they should only be considered where a patient can't incidentally brush. Now, that's a very subjective word, can't, isn't it? Is it that they can't, or is it that they won't, or is it that they just haven't been taught right in the first place? It seems like a really easy quick fix to patients, and they spend a lot of money, don't they? But I'm still wary. That said, I actually really like the idea of water irrigators. I think patients are very compliant with them. I just don't think that they're quite there yet. Certainly, they're not at a stage where they can be seen as better or equal to brushing with mechanical or manual. For me, they're just not powerful enough yet to break down that mature biofilm, and it's the mature biofilm that's the problem, isn't it? But like I said, they do excite me, and whilst I think the technology hasn't quite hit the mark yet, I do think it will do. I do think it'll get there. I hope that it will do. And when it does, I think we'll be looking at a whole new dimension to home care regimes. So I'm watching that space very closely, and I suggest you do the same. There are, again, like mouthwash, circumstances in which I would look at introducing them. But they're a bit of a last chance saloon for me, a last resort when everything else has failed, and only in very specific cases. So maybe where there's an implant bridge, but only if it's an implant bridge that the patient can't clean otherwise with other modalities, then maybe they're better than nothing. And I have seen mild to moderate improvements in those cases where patients couldn't clean. And they've bought a water jet, but I can't really recommend something based on it being better than nothing, because nothing isn't where we set our benchmark. It has to be a case that a patient physically cannot clean that area, usually because of the design of the restoration, rather than them not mastering the technique. So it's rare I bring them in, but it would be wrong of me to say never. It's just not something I advocate routinely because, like I say, they're just not there for me for now anyway. So let's talk about the three more important aids that we really do need to get our teaching right on. So that's toothbrushing, interdental brushes, and subgingival brushes. So first up, subgingival brushes. Now, these really do excite me, I have to say. Genuinely, this is the thing that I advocate the most in my periodontal patients, ahead of perfecting anything else. If you're not routinely getting your patients to push an interspace brush into their pockets and physically brush the tooth surface inside the pocket, then you don't know what you're missing. I first came across this on a Philoa course 10 or 12 years ago, and I was blown away by the case studies that Phil showed. If you attend perio courses or listen to Ian Dunn speak, you'll see he's picked up that baton and is showcasing similar case studies now. So look out for those if you can. I've always been about minimal intervention. Right back 20 years ago in dental school, invasive treatments just didn't seem right to me. So the very idea that we could get significant pocket reduction and significant bleeding reduction non-surgically without any intervention from me was something that really excited me. There's also now some really good clinicals to support this approach now. So the study named at the bottom of the screen, I think it was a split mouth study that was done. No clinical intervention at all. So just oral hygiene instruction. I think it was 3 OH visits that the patients got, and that's all. And the patients were taught to root brush. So when they looked at these patients again, just 2 weeks later, there were no change to the sites where the patients hadn't used subgingival brushes, but in the sites where they'd done successful root brushing, the BOP had been eliminated. So they'd halted the disease activity, and the pocket probing depths were reduced by almost 2 millimeters. That is a massive amount. To take a bleeding 6 millimeter pocket to a non-bleeding and stable 4 millimeter pocket in just 2 weeks with no clinical intervention, purely by getting the oral hygiene right, is incredible. Why wouldn't we focus on that? And we mustn't underestimate the power of that. And that's why we focus on the OH and not so much on the scaling. I really like the CTS Super Slim, which is the one you can see here, because I find the bristles a bit longer than some of the others. But I can't claim to have tried them all. I'm not going to pretend I have. This is the one that works well in my hands. I find the handle is sometimes a little bit too slim, so I have been known to use a standard one and cut half the bristles off for the patient. They're quite easy to adapt if you've got a nice little pair of surgical scissors. When I said earlier that my patients make me look like the world's best hygienist, how conceited. But this is what I'm talking about, because honestly, if they nail this, then it is chicken dinner time. Now, in general, patients who don't fully understand what they're trying to achieve and where the undisturbed bacteria is and why they need to get to it, these are the ones who struggle the most with this technique, because whilst there is a technique to it, once you grasp the concept and you understand what you're trying to achieve, it actually becomes a lot more achievable. It's not much trickier than getting their toothbrush right. We're intelligent human beings, and we're very, very manually dexterous. So this for me is more about confidence, and that includes us, the clinicians, too. I hear of hygienists and therapists who aren't convinced by this and aren't confident teaching it, and patients will really pick up on that reticence. It shouldn't be seen as a last resort for me, something we'll come to if nothing else works. This should be in their plan from the start. If you don't end up needing it because the toothbrushing and the incidental aids alone achieved enough resolution, then even better. We can praise the Lord and tell our patients they've done such a fantastic job. They've actually cut out a whole stage, and they'll love that message, which is very different to nothing else has worked, so we're going to try this. We're back to thinking about the messages and the language that we give out, and properly planning the oral hygiene steps so that patients know what we plan to introduce, so they know what's coming. Where I sometimes find this goes wrong, and patients call it what they describe as it's too difficult, is when they're kind of scared to do it, either because they think it's going to hurt or because they find it painful, or actually more often they're just too squeamish. So for non-clinical folk, the thought of sticking anything foreign in places that weren't designed to receive foreign objects really turns their stomachs, and patients are screwing their eyes up and turning away from the mirror and trying to do it with their eyes shut, which just makes it almost impossible. That's where stage one of motivating them in my last webinar comes in. So once that switch is flicked in their minds and they want to learn and they want to get it right, generally with some good lessons and good coaching from us, then they can figure it out, they can do it. They just need the confidence and a little bit of practice and quite a lot of praise from us. So when I'm demonstrating subgingival cleaning, I always show them inside their mouth, not on a model. Always. This is a no-brainer for me. Looking at it on a model is nothing like how it looks and feels on themselves, on the patient, and they need you to support them through that. They need to see the bleeding, they need to feel any discomfort in the safety of the surgery where you can reassure them and guide them. I tell them what I'm going to do and why I'm going to do it, and then I show them how to do it, and then I ask them to have a go in front of me. I give them the brush. I ask permission for me to hold the back of their hand, and I physically do it with them holding the brush and me guiding their hand. And then I gradually take my hand away and let them take the reins. So it's a bit like teaching a child to ride a bike, to hold on the back of the seat until they've got it, and then let go when you think they're ready, and hope they don't go crashing into the garden wall. These instructions are very simple, and the way that I teach this to my patients is very similar to that. So the instructions are splay, push, wiggle. You'll definitely have heard those 3 words with this brush before. So they splay the bristle against the tooth surface, they push the brush under the gum until it stops, that's very important, and then they wiggle it about to disturb the biofilm. I've got a video here that I can show you that might explain it a little bit better. So here we go. So hopefully you can all see that. So splay, push, wiggle. Splay, push, wiggle. So I tell them to walk the back, the side, and then the front of each tooth. There we go. Those eagle-eyed or eagle-eared listeners today will probably hear the music in the background, which completely contradicts what I've just told you. Sorry about that. Just realised that. Maybe that's before I decided I needed to turn the radio down. Now, the patients will often ask, is that not just pushing bacteria further under the gum? They always say this, don't they? And it's actually quite a logical, I praise them when they ask me that, because it is actually quite a logical question to ask. And the simple answer that I give is it doesn't matter. Bacteria under the gum and in our mouths isn't the problem. The problem is when that bacteria is left undisturbed. That's when it becomes a problem. And unless the patient physically disturbs it or pops the bubbles, as we said earlier, then they'll never get the disease under control. This is an absolute must in their periodontal home care regime. We're not debating this. I don't always introduce this at the start. In fact, I rarely introduce it at the start. So first we'll get the brushing right, and then we'll work on interdental cleaning, because you'll get a lot of resolution with good brushing. And then we introduce the interspace brush as their dexterity and their confidence improve. So it's always there in the lesson program, so they know we're going to come to it, but sometimes we don't have to use it, and that's great. It's horses for courses, isn't it? So sometimes I do have to bring this in straight away sometimes, but more often than not, especially in the big perio cases, we'll bring it in a little bit later. Patients know that we're building up to this optimum oral hygiene peak, and that's why there are several different lessons, that word again, involved. We're building layers at a pace that's right for them and right for their ability to adapt and master techniques, and it's right for their periodontal disease. So don't expect your patients to get these techniques right first time, like I said, and make sure they know that you don't expect them to get it right first time. But you'll tweak and adapt and adjust and modify as you go along and as they become more competent. So interdental aids, let's move on. Let's not beat around the bush. Interdental brushes are the device of choice for interproximal plaque removal, aren't they? Particularly in perio patients. If the space is big enough to take an interdental brush, then that is the device of choice, and there's lots of studies to support that. I'm not going to go into these today, and that's regardless of what the newspaper's telling us. Interdental brushes win hands down over everything else that's available out there. Putting floss or a wood pick or whatever else it is in our perio patients that have got spaces that are big enough to drive a bus through is just like using a pipe cleaner in a drain pipe. Total waste of time. I know there isn't a clinician listening who doesn't get this, and we'll all have our favourites, so I won't dwell on it. What works for one clinician doesn't work for another. What works for one patient doesn't work for another. All I'll say is that I have quite a range, so that if a patient isn't getting it and really isn't mastering the technique, then I have the option to change them to a different brand or a different product. I find the standard short plastic handled brushes, whether they're TP, Icon, Wisdom, whatever you use and whatever works well for you. The visual patients tend to get this better than anybody else because they tend to have very good hand-eye coordination, and I can place them very well. I find vision brushes work really well in the hands of very kinesthetic patients where the incidental pockets are quite deep because they require you to be able to sort of feel your way through. I like the vision brushes. The bristles are a little bit longer on the vision brushes, and I've had an extra millimetre or so resolution in some cases where I've had an incidental pocket, and I've switched off standard brush and onto vision. Vision aren't as straightforward for the patients to purchase, so I tend to go with standard incidental brushes initially, and then I'll use vision in site specific areas where the patient's struggling or I've not quite got the result and the resolution I wanted, and I'd probably do that at the time that I start introducing subgingival brush. So I tend to mix it all up. I guess that's what's saying. It's not one size fits all, and we have to figure out what's going to work best in our patients' hands as well. And their needs will change. So for our big perio cases, those sizes need checking. I would say every visit until they're stable, and then probably every 6 months or so thereafter. Certainly in the first couple of years after treatment, when gingival contour can still be changing for quite a while. It's more important than what we're using, I think, is making sure that we size these brushes up correctly. They should be snug. So where there's lots of inflammation, remember what we're trying to achieve is tissue shrinkage. And you'll find as they squeeze through and against that inflamed gingiva, they'll squeeze subgingival debris out and explain that to your patients. They always seem to quite like that idea. So the brushes don't want to be so tight that you cause trauma or you can't move them, but they do need to be snug and snug enough to do a thorough job, whether the patients like it or not, and you can explain why that's important. One of the biggest problems I see is undersizing of incidental brushes. You can't eyeball this when there's inflammation present. You can do what generally where the gingiva is very healthy, but you can't where there's inflammation because you don't know how much wiggle room there is under that raised gingiva. So you have to size these brushes up and keep moving up in size until you can't go any further. Sometimes I'm amazed what goes through. I'll start at what looks like green and, you know, I might end up at grey or black. Patients like to undersize too because it's more comfortable, isn't it? I tell them, you know, if you're putting a yellow brush in a space that's fit for a purple, all you're doing is cleaning an empty space, and that's not going to do anything. You want the bristles to splay out subgingival, and that won't happen if they're working coronal to the gingiva. That's just common sense. And also remember to tell patients not to drag them down centrally into the gingiva. We've all seen this, these little the trauma wear facets in the gingiva where patients are pulled down, usually in the lower arch. So get them to think about the tooth surface either side of the gap. So I tell them to push up against one side and brush, and then change the pressure to the opposite side of the gap and push up against the tooth surface so that they're not sitting in that central space. Whatever you do, write this down, especially in your perio cases. You can write on the back of a scrappy piece of paper if you want to, but patients cannot be expected to remember. In the early perio stages, patients might need 5 different colours. There's no way they'll remember that or figure it out for themselves. They need a map. And here is one that I made earlier. I put this up last time. I had loads of requests for it. Again, feel free if you want it, or take a screenshot of it and copy it, whatever. It's nothing special. It's just something I threw together. And honestly, as I said last time, of all the things I've done over the years, this is the thing that patients absolutely cling to. It's personal to them, and they genuinely depend on it. We rewrite this each time. A nurse usually fills it in while I'm talking, and we'll do a new one each time until I'm happy that they're stable and the patients really genuinely appreciate it. It almost adds another layer, emphasizing how serious this is and how important what they do at home is. So it's got their name at the top and the date and the bleeding score and the plaque score. There's a couple of lines there just reinforcing the message and reminding them that it's personal to them, and it, you know, it's not for the husband and the dog and the cat and everybody else. And she'll fill in what toothbrush I've recommended, toothpaste, whatever it is. Make sure you write words that they can understand. And then down at the bottom is their site-specific interdental map. So it says working from the first space on the top left. So that's the first space on the top left-hand side of the mouth. And we'll go along and write whatever it is. I'll call out as I'm sizing, my nurse will write 1 grey, 1 purple, 3 green, 4 yellow, whatever it is that I'm saying. And so I tell my patient, just follow this map, and then it goes down to the bottom. Patients really do cling to this. And the rules, the golden rule that I give to patients is that they're allowed to increase the sizes, so they can move away from the map and increase the sizes if the brush starts to feel loose, which I would expect it to in those early stages, but they're never allowed to decrease the size. So rarely would an interspace size go down. Especially in perio cases, unless they've had a restoration change, and that would be something different. So they're allowed to move up, they're not allowed to move down. If they find I've written whatever 3 grey and they're saying they just do not fit, you've definitely written the wrong size, Faye, well then that's a technique issue, so they have to ring up and come back in and let me help them get to the right size, because it's a waste of time them reducing it to a yellow and saying I could only get yellow in, so that's all I did. The other thing I tell them to do is smell the interdental brush after they've used it in each space. If it smells, then that site needs a little bit more work and they should probably go back in there. Disgusting as it is, let me tell you, if they think they've got a smelly pocket or a smelly site, then they clean it like their life depends on it. Just you wait and see. And also, if you explain what that smell is and why it's there, then it just adds to that message about undisturbed bacteria being a problem and so on. So watch your sizing, folks. Snug fit, but still room to maneuver it. The patients will complain they're too big and they're worried they're going to wear the teeth away and the gums away, but we're there to reassure them. We're on their side. We're not going to do anything and recommend anything that's going to cause them a problem and wear the teeth away. So just reinforce that message, reassure them, give them lots of support. Try not to roll your eyes when the 10th person of the day says the same thing to you, and then loads of praise next time you see them. So that leaves toothbrushing, which I want to talk in detail about today. And now, before we get into this, we need to talk about recession. So last time we talked about how the things that we say to patients can give the wrong message, and we talked about banning the word calculus, which loads of you, like I say, have messaged to say you've taken on board, which is fabulous. Now the bad news, and what I didn't tell you, was that you actually need 2 boxes. So you need a calculus swear box and you need a you're over brushing swear box, because if there is one thing that drives me completely nuts, even more so than talking about calculus to patients, it's this: telling patients that they're brushing too hard, or even worse, telling them they're wearing the gums away, or any other version of those sentences. It might be true, their technique might be terrible, and there are some cases where it does happen, but oh my days, trust me when I say this, the second, and I mean the second, you say these words to a patient, and especially if they come out of the mouth of the demigod that is the dentist, patients stop. They stop cleaning effectively instantly. And it is so hard for us to claw our way back from that. Let's think about it. And I know I'm preaching to the converted, but let's just think about where this goes wrong. So soft tissue follows hard tissue, right? We know that. We're hygienists and therapists. We know that. If there's bone loss, like in periodontal disease, then there should be recession, because the soft tissue in health lays maybe only a millimetre or 2 over the bone. If there's bone loss with no recession, then that's a pocket, and that's a problem. So what we want to see is recession. We're actually trying to get recession in our perio patients. 70% of the pocket reduction in a perio case comes from recession, 70%. So recession is one of our treatment goals, because that signifies pocket reduction. It tells us the inflammation's reduced or even gone away entirely. I tell my patients, gums don't hold your teeth in, bone holds your teeth in. Think of gums like skin on the inside. So the same way that our skin covers our bodies up on the outside, it's our first line of defense and it's there to protect what's underneath. That's the job of our skin. Gum does the same job. So gum's our first line of defense inside our mouths, and it's there to protect the bone underneath. Depending on what age group I'm talking to, I have all sorts of different analogies for explaining this, and I could spend a whole webinar just talking analogies alone. I don't know where they come from, honestly. But for recession, so maybe if I'm talking to an older patient, I might bring the war in. They love this. So I tell patient that gum is like a personal bodyguard for the bone. So it should follow the bone and stay really close to its man. The only time it will pull away from its man is if there's danger and attack occurs. So what happens in perio disease, the bone retreats while the gum stays and fights. And once that attack's over, then the gum will go back to the bone. The bone doesn't go back to where it was, it stays retreated. So the gum's got to go back to that retreated place and stay close. Once again, never leaving the side of its man of the bone. Guarding it, protecting it, and the old dudes absolutely love this. And I've got another 15 that I say, depending on what age group and who I think sat in front of me. So whatever analogy I choose to use, the message we have to get across is that as the gum shrinks to the bone level, which is where it should be, it leaves a portion of that tooth exposed, and that was once covered by bone and gums, and it's good tooth and it's strong tooth. It's just not as covered up as it once was, and you can reinforce that in the literature. It mentions it in the perio and gingivitis, sorry, not the gingivitis, the perio sheets that I mentioned last time. And so they can sort of digest that information a little bit better at home. Now, where it all gets muddled up, when they get the recession, which they kind of accept if you explain it well, is when they also get pain from sensitivity. They don't like that. So we're naturally programmed to know that pain signifies something is wrong or something is misfiring somewhere. That's why we have pain receptors. So if we filled our patient's head with the idea that the recession's going to happen and it's okay, but they go home and develop pain in the form of sensitivity that we forgot to warn them about, then it's only natural that they're going to equate this to things not going to plan. So we must remember to warn them that their recession will most likely result in sensitivity, usually temporary, but that's to be expected because they've now got root exposure, especially if cementum's been removed during the debridement stage. Then you'll find the sensitivity is exacerbated because the dentine, the tubules are exposed. Now I'm getting to my point. So what's hard for the patient to understand is that the improved brushing isn't the cause of the sensitivity. The recession is the cause of the sensitivity, and the recession is the result of disease. Sensitivity is just a side effect. It's not because the patient suddenly started cleaning well. It certainly isn't because the technique that we've taught them isn't right. Patients, but also worryingly clinicians, sometimes equate recession and the sensitivity with poor technique, and we're all kind of guilty at some stage of doing this, when actually, think about it, the brushing technique had nothing to do with it. That's purely eliminating the inflammation in the pocket and exposing the roots, which then feels sensitive. The sensitivity is caused by the tissue shrinkage. It's not caused by over brushing. It's actually caused by correct brushing, because if you're not correctly brushing, you leave biofilm undisturbed, so you don't get the healing and you don't get the shrinkage. We should be praising recession in our perio patients. I go all out when I see tissue shrinkage or they mention it and patients say they've got a bit of sensitivity. I tell them that is fantastic news. I'm absolutely thrilled, and they look at me going out, and I tell them it's music to my ears and that's exactly what I want to hear, and they're saying all the right things, and it means they've been doing everything, and it means that the healing's taking place, and so on and so on, and try and put this positive spin on it, because this is a really good sign. So educate your patients so they fully understand what's going to happen, and give credit where it's due. Now, where it all goes wrong, which is the point of this slide, is when the patient either weren't told or didn't understand properly. So what they do, they pop in to see the dentist complaining of sensitivity. And what was the dentist that I was working with saying? You've got some recession and you're causing trauma and you're brushing too hard. Oh my days. It literally made me want to scream, because what do you think the patient does? They forget everything, and I mean everything that I taught them, and they go back to the paw brushing technique that caused the perio in the first place. Now, let's be fair, that might not be exactly what the dentist said. Patients hear what they want to hear. But it's what the patient took away. So we must get this wording right. We must give out consistent messages. We must be aware of the impact that our language can have, and we must have this conversation with our referring dentists. Firstly, to be sure that they actually understand that post-op recession and sensitivity is a sign of healing, and it's a good sign in a perio case, and that it's not a sign of trauma. And secondly, we need to have a conversation so that they know what to say when, and it will happen. So when this situation arises, because we could have spent an hour undoing all those long established fears and anxieties and distorted thoughts because the dentist told them 50 years not to brush too hard, and we can't have all that hard work done, whether it's accidental or not, in one sentence by the dentist. Because how do we come back from that? So it's far better to preempt this. Decide how you're going to deal with it, what you're both going to say when it arises, and choose words that support and reinforce your initial teaching. The message is very clear. Recession and sensitivity are inevitable if periodontal disease is to be eliminated. No ifs, no buts, no way of preventing it. It's like holding a wave on the sand when the tide pulls back. It too, so too does the wave. It's simply not possible. The hard tissues will do what the hard tissues do, and the soft tissues are going to follow. It's just natural tissue resolution, and we should all be praising that. If you heard Ian Dunn's lecture with the BSDHT a couple of weeks ago, he talked about a sentence he says, which is, you know, you have a choice, you have a longer tooth or a tooth no longer. I can't remember who he said initially came up with that, but I think it's brilliant, and I say it all the time to my patients. So they're not wearing anything away except perhaps my nerves. There is simply natural tissue resolution. So when they come in, tell them that's brilliant. It means the treatment's working. Praise the Lord, Mrs. Smith. You know, you're a genius. Best resolution I've seen all week. Those gums look fantastic. We have to take responsibility for the messages we give out to patients and really understand the long-term impact that they have. So talk to your colleagues, re-educate them if you need to, come up with a phrase that suits everybody. You can work on this together, and seriously, we have to own this. And as with the calculus box, if that fails, then shake your money pot at them, and they'll soon get the message. If you thought I made a killing out of the calculus box, you should see what I made out of the "you're brushing too hard" box in the first 6 months. I think I could have holidayed in the Maldives on the back of that. I've actually combined the boxes these days, and the dentists run a mile when they see me marching down the hall with this tin. It's all in good faith, and actually it's really made them think twice before they blame the brushing technique immediately. And they know if they get it wrong, then like I say, I'm gonna throw this tin at them. Okay, so let's look at this actual brushing technique, because we really do need to get this right first and foremost. And it blows my mind how much of this varies in standards between the clinicians, never mind the patients. One of my many jobs is going around teaching dental teams in-house, and whichever member of the team gets in the chair gets disclosed. And you would not believe the plaque scores that I see among dental clinicians. Rarely hygienists, to be fair, but often dentists. You wouldn't believe how many dentists or therapists or hygienists, when I teach this technique, say I didn't know that after I've done their oral hygiene. And like I said, any dentist I'm working with gets an oral hygiene lesson with me, so they know what I'm teaching, and we're all sending out the same messages. I haven't yet taught one dentist this technique, and they haven't said to me I didn't know that. So think about getting your dentist to sit in on one of your OH sessions with a patient, so that they understand what you're teaching, and the message flows throughout the practice. I think we were taught every manual toothbrushing technique under the sun when I was at dental school, but no one ever taught us specific electric brushing techniques. So this is very much my baby. we think we know, but what's that based on? And once you get into it, you'll see what I mean. We have to nail this. It's the difference between perio being managed and not being managed. And no matter how long it takes and how many lessons it takes, we have to get this right. We just have to make it work as best we can anyway. I'll very quickly mention this. It's horses for courses, I agree, and there'll always be exceptions to the rule, but in the majority of cases, oscillating, rotating electric toothbrushes remove more plaque bacteria than manual. I know there are patients who achieve greater things with manual brushes, and I say leave them to it if there's no problem, but the evidence on this is very clear. If we look at the Cochrane collaboration, they confirm the superiority and effectiveness of the oscillating, rotating powered toothbrushes. Also in these systematic reviews is confirmation that rotating, oscillating power brushes were just as safe for hard and soft tissue as manual brushing was. So don't have patients or colleagues or anyone else tell you that the electric brush causes recession, because it doesn't. Don't get me started on recession again. I'll never shut up. It's poor technique that causes trauma, and that can be bad whether it's manual or electric. When it actually comes to giving toothbrush instruction, this, I think, is our greatest asset. I said this last time. I just think we're so lucky. I cannot believe how many hygienists and therapists don't fully utilize these test drives. It's free. We don't have to do anything. We don't have to pay for it. Every clinician in the practice is entitled to one of these, and every clinician that has one can order up to 200 heads a month. We have this diarised, and reception know on the first of the month they ring up, they order me a new box, and there's no issue with stock as far as I know, or there wasn't pre-COVID. This is such an incredible asset. What Oral-B had to go through to get this passed so that it was classed as safe for our use is off the chart. It went way above CQC. Actually, it had to go through the FDA process for medical equipment and pass their protocol for safety standards before it could be approved for us to use, which actually means it's passed a really robust disinfection process at a level far higher than what we're currently dealing with. So it's more than safe in terms of cross-contamination, in my opinion. In terms of splatter, we're going to get onto that at the end. So for me, this is the only way to give good electric toothbrushing instruction. Patients need to feel the pressure, the sensation. If there's lots of inflammation, they need to see the bleeding in their own mouth so they don't panic at home. Doing toothbrush instruction on a model does not come close to using this brush on them, in my opinion. And also, you know, if you're demoing on a model, then it's impossible for you to check the patient's own technique. How do you get them to demonstrate back to you? It's an incredible resource, and one that should be utilised at every appointment. The test drive is laid out on my tray for every patient, along with my other instruments. And for me, it's the most important tool on there. My patients expect this to be a part of their appointment, and then they expect me to pick it up at some stage during that appointment. So there's a technique to everything, isn't there? Everything that we do, there's a technique to it. Knowledge increases knowledge. It doesn't necessarily change behaviour. Remember, we talked last time about barriers to behaviour change. So not understanding instructions was a big one. So getting this right is really important, and being clear and concise when demonstrating that technique is all part of that. So who thinks they've established the perfect technique? There actually isn't one right answer to this, although there's quite a few wrong answers. I know this because myself and Julie Deverick, our current BSDHT president, and Michaela O'Neill, our former BSDHT president, who I'm sure you all know, we sat down together about a year ago, and we spent some time figuring this out ahead of some filming that we were doing. And we had some different ideas, and actually it took the three of us quite a while to reach a unanimous decision, and that's because there's lots to consider. And this is why, when I said earlier about starting with the basics and building layer upon layer as you go, that's why it's so important. So I think things to consider are things like angulation, pressure, grip. Do you lift the brush on and off? Do you maintain continuous contact? Where's your elbow? Where's your arm? And so on. And then there's the big one. Do you teach over the gum or do you teach under the gum? I want you to really think about the answer to that question. Keep it to yourselves. You don't have to share it. But just think for a minute. I've asked a lot of delegates this question before, and most start off saying half over the gum, half on the tooth. So I want you to stay with me on this, because I suspect that's what most people listening are thinking. Just keep an open mind for a minute. Think about everything that we've just said about subgingival cleaning, and think about where the undisturbed biofilm tends to hide. Is it on the outer surface of the gum, or is it subgingival? If it's subgingival, and knowing what we know about the incredible results that subgingival brushing can have, then why are we teaching over the gum? What's on the outside of that buccal gingiva that needs brushing? So you see where I'm going with this. If the bristles are at 45 degrees and half over the gum, then are any of the remaining bristles going subgingival? Possibly, possibly not. Are they penetrating into proximal? A bit, maybe. And yet, where's the majority of the mature biofilm? It's subgingival and it's interproximal. So that's where we should be focusing. So let's just see if we can rethink this a little bit. Stay with me. So the technique that I'm about to show is by no means the only way to do this, but it is one way, and it's the way that I teach. And once I developed this technique and started teaching it to my patients, I very quickly started to see quite a seismic shift in bleeding scores. And I'll explain the reasons behind it as I go along. So I call this technique push, don't brush. There you go. Now you know where the title comes from. You won't find it called that in any textbook anywhere in the world or in any official guidance, because I made it up, and you are very free to start using it. And if you ask any one of my patients how they clean their teeth, they will all say this phrase back to you, and I am not joking. Patients write this in my Christmas cards. I've had thank you flowers sent with this written on the card. It was my birthday yesterday. One of my colleagues sent me a bunch of flowers with push, don't brush, we miss you written on it. Patients have even shouted this phrase out to me in the street. I kid you not. Faye, push, don't brush. That's what I heard shouted at me across the street. It's an actual true story. And if I ask them, what do you remember about your last visit? This is always the phrase that they say back to me. I get them singing it to their favourite tune while they brush, and I sing it to them sometimes too. When I started my last new job, within one day, my boss was in my surgery saying, what on earth is push, don't brush, and why is every patient saying it to me? I had my boss in the chair that day and disclosed before he could say Bunsen burner. It's very funny. So now I'm going to share it with you. So the basics of push, don't brush technique. Number one, the bristles go under the gum, not over it. Tell the patients their job is to clean the bits of tooth that they can't see. That's the message I say to patients. The bits you can see aren't important. The bits you can't see are the ones that are most important. So that I tell them they're the areas where the bugs like to breed, because it's dark and it's warm and it's moist and it's sheltered and it's protected. And if we wanted to grow pretty much any microorganism, that's exactly the environment that we'd create. So number one, focus their minds on the bit that they can't see, and they'll still hit the other bits, by the way. They can't avoid that, but their eye line will be focused on penetrating the bristles beyond the gum line and into that bit that they can't see. Number two, here it is, push, don't brush. So you're not cleaning a flat surface, you're cleaning something that's round. So you have to go around each tooth and follow its contour. The head's oscillating, it's spinning round and round, it's doing all the brushing for them. They don't need to brush. I actually say, I want you to stop brushing and I want you to start pushing. Their job is to push those bristles between the teeth and feel for them coming out the other side. And you can discuss the red light on the brush at this point and reassure them that the light indicator will prevent them from putting too much pressure on. And then thirdly, the third message is to focus on interproximal bristle penetration. So tell the patients, especially from the lingual and palatal aspect, to look for the bristles coming through. That's when they know that they're where they're supposed to be. It's quite difficult to describe this without showing you, not dissimilar to when I'm teaching OHI to patients. See what I did there? So I'm going to include a couple of videos now of me giving OHI to my patient and then on my nurse. Now, this first video shows perfectly what I mean when I say teach the patient to put the bristles under the gum. Some patients are wary of this initially, but they do get used to it. We're there to support them, especially if we get that message right. And we'll see some quite rapid reduction in the amount of bleeding. Now, disclaimer, I want you to ignore the fact that I'm pressing on quite hard in this video. Patients would be shown to adhere to the light guide, but I wanted to emphasize the subgingival aspect for the purpose of this video, and that's why I'm pressing on much harder. You'll see what I mean. So watch closely. Tell me that a technique that went over the gum at 45 degrees would be better than this technique that sends the bristles careering into those subgingival pockets. You'll notice the push don't brush that I tell my patients is 3 times on each surface. So look out for the cupping. So you're asking them to try and cup each tooth as they go along. So here we go. So you can see, similar to the interspace brush, backside and front, they're just cupping each tooth as they go along, trying to get those bristles under the gum and in between the teeth as best they can. Sorry, it's a bit wobbly, the video. Now, that's clearly a perio patient, and I don't want you to think that this technique only applies to perio patients, although that's where it has the biggest impact. So the next video shows me giving oral hygiene advice to a patient without perio disease. It's actually my nurse. Before I get onto that video, one of the things that I get most comments about on this video is the incidental penetration of the bristles, particularly from the lingual and the palatal aspects. In your non-perio patients, if they get this right, not that I tell them this, they can actually almost get away without incidental aid. So it's especially important in those patients that don't or won't or can't incidentally clean, and that's why I put so much emphasis on perfecting this. So you know, looking for those bristles coming out in between the teeth, it's a really easy guide for patients to follow, and they seem to really cling on to this bit because it's such a simple reference point for them. They know that if they see the bristles coming through, then they're getting it right, or they're certainly well on the way to getting it right anyway. So I'm not going to talk over the top of this video because I think it's useful for you to hear me just delivering oral hygiene advice that I would deliver to a patient. So this is me giving toothbrushing instruction to a patient. Well, she's actually my nurse. Try not to be distracted by the frenum piercing. Believe me, I have told her. In particular, I want you to take note of the guidance about using the bristles interproximally. Like I said, looking for them coming through from the lingual and palatal aspect. So here we go. I'm just going to play it and let you listen to it. Yeah, so hopefully you find that useful. It's not the only way to do it, but it's the way that I do it. And I always find it really helpful listening to other hygienists and therapists giving oral hygiene instruction, because there's just things they say or tips that they do. I learn from everybody. I do lots of mentoring, so I have lots of hygienists come in and sit in with me, and it's just useful to hear how other people work. Like I said, this is the thing that I think I get the most comments about when I teach this technique, is those bristles coming through from the lingual and the palatal aspects. It's a really useful tool for patients. So we're almost there. What I'd like to stress is that demonstrations aren't a one-off. So it's not something we do and then we move on. Things change. The landscape of the gingiva in perio patients especially will be changing a lot in those early stages, but they constantly need reviewing, because other things change too. Levels of motivation, levels of dexterity, things are added, things are taken away, and I think if we don't make this the focal point of every appointment, then it will lose the gravitas that it once had, and our patients lose motivation, and that's when they start to see us just as scaling machines. Every patient I see knows they're going to have the bleeding score checked and their oral hygiene regime and techniques checked too. How can we justify not making this a priority? And actually, my patients have come to expect it. So they start to feel that they've had a disservice if I don't check it. Honestly, I have genuinely had patients go through to the dentist and complain that I didn't go over their oral hygiene and I didn't give them any further instruction. These are patients with zero, and I mean zero, bleeding scores, zero periodontal disease, zero plaque scores, but they feel as though they didn't get their money's worth because I didn't give them any new information, and that's because we focus so constantly and so heavily and almost entirely on bleeding scores and oral hygiene instruction. So keep picking that test drive up, keep resizing those TPs, keep reviewing their techniques, and helping them to deal with any hurdles that they come across, because it really is an ever-changing landscape. The test drive isn't something you do once and then you forget all about it. Before we finish, I would just like to mention this brush, and not because anybody's asked me to, but because I am so excited about this brush. It was supposed to be launched at the dentistry show in May, and obviously that didn't happen, so it's now going to be launched at the end of this month. In fact, next Friday, I think it is, but it'll be a virtual launch, and I cannot wait to get my hands on this. Yes, it's got a few extra slick features, but they're not what I'm excited about. Those of you that have heard me speak before will have probably heard me banging on about this, because I have been banging this drum for years. The pressure sensor, so the red light on the existing brushes, is great for the over brushes, but in my opinion, it's almost created a second wave of problems for us in clinic, in that by putting a red light on, it gave patients a message that damage could and would be done if ever they went across this red line, and it gave the subliminal message, although it's not what Oral-B intended, that there was danger ahead and damage that could be done. That in turn, I believe, created a nation of underbrushers. Now, I don't know about you, but I see far more issues in clinic with underbrushers than I ever see with overbrushers. Think about how many people you see who've actually caused a problem with a toothbrush, an Oral-B toothbrush, that resulted from overbrushing, and think about how many patients you see with problems that stem from underbrushing. The message was all muddled up, and it was all wrong for me. So what I wanted to see was a brush that not only told patients that they were over brushing, but also told them when they were under brushing. And at last, my friends, it is here. It's called the IO, and it has what Oral-B are calling a smart pressure sensor, which means that it has one light for under brushing, one light for over brushing, and a green light to indicate that they've hit exactly the right pressure. And I am thrilled that someone has finally done it. If I'd had a few £1 million, then I'd have done it myself. This is going to change the game for us, and if nothing else, it will get us in clinic talking about underbrushing as much as the red light got us talking about overbrushing. It really is time to move away from this generation of patients who actually believe that they can brush their teeth away to nothing but stumps. It's nonsense. Instead, let's tell them what damage underbrushing does and start a new wave of thinking. you know me, I love a revolution. The other thing I really like about this brush is that Oral-B have got rid of the motor in the brush. You'll have heard patients saying in the past that they don't like the heavy vibrations on these brushes. So what patients will find with this new model is that it feels very smooth when they're using it. It no longer feels like this hammer drill. So I think that's another great move by Oral-B. I can't wait to get my hands on it. I keep getting promised mine's on the way, but Mr. Postman hasn't brought it yet. So I don't know. Let's just very quickly mention this because we're out of time now. So we're almost there. I just want to give you my thoughts on delivering intraoral or oral hygiene instruction post-COVID, because I know this is something that's open to great debate at the moment. These are just my thoughts, and I can't tell you what's right or what's wrong for you. Only you can make that decision, and it has to be based on how comfortable you feel with it personally. And as I said, these are just my thoughts. We do have clarification now that we can profit. So if we can profit, then we can also do intraoral oral hygiene instruction, in my opinion, because it's creating the same splatter. It's not generating an aerosol, it's generating splatter. And for me, splatter is splatter, whatever the source. We'll need our PPE on, and it means we'll have to be organized, so we're not going in and out of drawers. But based on the fact that we can use a slow speed to profit in England, if we follow the same guidance, so we dry the teeth first with gauze, I don't see how a test drive is any different to a slow speed. For me, the same applies for the spittoon and anything else that causes splatter. The droplets are heavy, they fall to the ground quickly, they aren't suspended in air like the microparticles we've heard so much about lately, and therefore they pose no more risk than they did pre-COVID. And our standard PPE measures laid out in the new SOP guidance will protect us from those. That's not to say that the splatter might not contain the virus. It's saying that it will fall quickly and will be cleaned away. It's not something we'll breathe in, which is where the real risk lays. Hence why there's no follow time following Prophy polish and intraoral OHI. So they're my thoughts. For what it's worth, ultimately it's your decision, but you're certainly not breaking the rules if you do choose to proceed with intraoral OHI at this stage of returning. I will of course be continuing with my intraoral demos, because for me and my style of teaching, demonstrating on models just doesn't work. So I will pick up where I left off, and I certainly won't be losing any sleep over it. So here we are at the end of part 2. I want to thank you for tuning in, and I want to wish each and every one of you good luck with your return to work. But more than that, I want to wish you strength to find your inner hygienist diva, and the strength to stand up and make yourself heard. You didn't come this far to only come this far, and you certainly didn't work as hard as you did to give up at the end of it. I said it last time and I'll say it again. This is our time to rewrite the script. You are holding the pen that writes that script, and I truly believe we'll never get an opportunity like this again. Push forwards, carve the path for the prevention-based practice care that you want to deliver, and that you want to be known for. Do what you know is best and right for your patients. You have the power, you have the skills, and hopefully after these webinars, you also have the confidence. Believe in yourself, believe in what you're trying to achieve, and don't ever lose sight of that. In the middle of difficulty lies opportunity. Go back to work stronger and more determined and more confident than ever, and be the hygienist or the therapist that you started out believing you could be. And if you don't remember anything else, remember push, don't brush, and remember to treat the person and not the perio. So that is me all done. Phew, we made it. Now then, how are we doing for time, Sharon? Because I appreciate I've been talking too much. Have I got time to answer a couple of questions?
If you're happy to answer the questions, Faye, I'm happy to sit here and, well, would you want 10-15 minutes, something like that?
Let's have a look. We'll have 10 minutes of questions.
You've got quite a few.
Let me see.
Faye, the video where you were doing test drive on your nurse was really quite juddery, and the sound, it sounded a bit like you were underwater. So I wondered whether, would you be able to provide that separately, and we
Of
can.
course I will. Absolutely. Yeah, absolutely I
It
will.
just sounded like you were underwater, and it was quite juddery. So I think if we could have that separately to sit aside this recording, that would be fabulous.
Yeah, so shall I send it to you, Sharon?
Yep,
And you
and then
can.
I can distribute it.
Yeah, no, that's no problem at all.
Okay.
Okay, so let's have a look. How long do you have for your lessons? So I have, it depends what I'm doing. Generally 30 minutes, 30 minutes an appointment. If I'm going on and I'm at the stage where I'm going to do lots of ultrasonic debridement, then that might be a longer appointment. I tend to do it in either just 1 or 2 visits, that side of it. But generally speaking, my appointments, my first appointment for a big perio case would be an hour. There's lots of explaining, there's lots of notes, there's lots of charts to take, and it just takes a long time. Half an hour. Sometimes they're very anxious, they've got lots of questions. Half an hour is not long enough, so I usually start off with an hour for a perio case. For a non-perio case, so gingivitis or a standard recall, then it would be 30 minutes, and we take it from there. I do what I can do in my 30 minutes, and I prioritize, and if I need a second appointment, which I generally do, then we offer a second appointment. If that patient chooses not to come for that appointment, then that was their decision. They chose not to come back, and I'm okay with that. I'd rather that I treated correctly and requested that second appointment that they chose not to come back to, than I tried to squeeze it all into one and then didn't achieve what I wanted to achieve. So generally speaking, the lessons are 30 minutes. So let's have a look. I've read that update states you're unable to polish at the moment. I would have a look at the BSP guidelines on this if I were you. It depends where you are, but in England, we're okay to polish now. Oh, now why can't I move my questions down? Oh, there we go. Okay. Can I ask which elbow and arm position you ask patients to adopt? So I'm very keen on them not having their wrists like this. So I don't like them to grab the brush like this and twist, because it's uncomfortable to hold your wrist like that. So naturally they go to straighten the wrist and then they pull out of position. So it's much better that you ask the patient to hold the brush like a pen, particularly for lingual and palatal. If they hold it like a pen, then their wrist stays straight, and you tend to find that they get that lingual position much better. For the lowers, elbow up in the air. So their elbow, they need to be really conscious of the elbow so that they're up in the air. Again, if their elbow drops, then they roll out of position. For palatal on the uppers, then their elbow needs to be down by the side and they're coming in from down below. So lots of kind of position changes. Buccally, their elbow's always up in the air. It's just palatal on the uppers that their elbow needs to drop down by the side. How do you disinfect the test drive between patients? Well, the test drive comes with a cover. Like I say, it's been through extremely robust tests. So it comes with a sleeve that is sealed up, and so it's completely clean. We don't have to do anything to disinfect it after we've used it, because that sleeve's removed. With a dirty glove, the sleeve's removed, the head stays inside the sleeve. As you pull it off, the head stays inside that sleeve, so that bit of sleeve that's then on the outside is clean, and then the test drive's just wiped and put away. We used to have to disinfect it when they first came out, but that's been lifted now. We don't have to do that anymore. Do we just go on the Oral-B website to get the test drive? You need to get in touch with your local Oral-B rep. You can go on the forums and ask who your local rep is, and they'll be able to get you sorted out with a test drive. There's a central number for ordering test drive heads as well, or you can get in touch with your reps and they'll order them for you. there was one problem with them, like maybe 2 summers ago with the heads, but that's long since gone. I often hear people saying you just can't get the heads. That's not the case. It's not true. The heads are readily available. You need the right number to ring, or you need to keep in touch with your rep regularly. There isn't, as far as I'm aware, there isn't a supply problem unless COVID's put paid to that. Well, we'd have to check with Oral B.
Faye, Faye,
Yep.
Michaela's just given me the telephone number, so what I'll do,
Oh, go for it.
On the recording, I'll include that telephone number as well.
Perfect. There you go. That's the number that I generally ring, the central one. Do you give your patients the Oral B head from the test drive to take home? No, absolutely not. First of all, it's a cross-infection concern, so I don't give patients anything that I've used on them. I know lots of people do, they put them in little plastic bags. I think certainly at the minute we certainly shouldn't be doing that, but more so the test drive head isn't suitable. It doesn't fit properly on their electric toothbrushes at home, so you're starting off on a no-win situation if you give them a head that doesn't work properly. If you force it on, which some people claim they can do, then you run the risk of damaging their toothbrush. That's not a good position. The test drive heads, that was one of the regulations that got the test drive passed, was that those heads went into clinical waste and didn't go home with the patient. So that's why they're the way they are. So no, I don't give them to patients. Could you provide access to your videos? Yep, sorry guys, I didn't realize they hadn't played properly. So yeah, I'm happy to share anything. I'm not precious about anything. You can ask me for absolutely anything that you want from me. You'll always get it. Do you currently brush your teeth as you demonstrated? Yeah, absolutely, I do. Absolutely. So does everybody in my family and all my friends and anybody that I can get 5 minutes with to teach push, don't brush to. What head do you mostly recommend for the Oral B cross action? The benefit and where the plaque and biofilm disruption comes from is it's in the directional changes. So when the bristles change direction, that's when they do the most amount of work. So the cross action head, I can't remember the figures, I can't remember how many directional changes there are, but because of the way the head's designed and the bristles are all at different angles, then you get more directional changes and therefore you get more disruption. So generally speaking, the cross action head, sometimes I will recommend the soft head to start with on perio patients where there's lots of discomfort and lots of tenderness and lots of inflammation. Otherwise, I reserve the soft head for patients, for instance, with mucositis who really are going to struggle. Otherwise, we get in there and we go for it. Don't like the feel of incidental brushes. Oh, cringe. I don't like the feel of anything between the teeth. What would you advise for patients that don't like the feeling? I mean, this comes back to stage 1, doesn't it? They've got to get over this. This comes back to what we were saying in the last webinar. If you plant those seeds and you fully prepare them and you get to a stage where patients really do want to get this right, then they tend to overcome this kind of wussiness that they don't like the feeling of something and get used to it. I'm not that hard on them, but I rarely give in to that. I do encourage them because there isn't another option. So what they're choosing is to not resolve their inflammation and not resolve the perio disease. So I hand that option back to them. You know, you've got to think about what you want to achieve from this. There's always an odd one. There is always an odd one. I'm not going to pretend there isn't. Can you please give this lecture to lots of dentists? Somebody asked me that last time as well. Absolutely. You just let them know where I am and I'll happily talk to all of the dentists. Is it possible to have some examples of your analogies? Oh my days, that's a whole webinar, honestly. Email me, ask me what you're particularly interested in and I'll tell you, because I think using analogies that they can understand is really, really important. The whole skin one, gum's just skin on the inside, it's protecting what's underneath it, really helps patients. And if they can see it like that, so I might say to them, you know, imagine you're washing your face. If you washed your face and it bled, you wouldn't think I better stop washing my face because it bleeds. You'd think there's something wrong with my face and I need to go and get my face fixed. And if you can get them to think about gum like it's skin, then they'll do the same. They won't just not brush that gum because it's bleeding. They'll think there's something wrong with the gum, and that's where we can come in and explain what that is. So I've got 1,000 analogies. You're probably better asking my nurse, because she rolls off a chair and dies of boredom when I start going on about different analogies that she's heard. In fact, the Christmas party this year, they had great fun around the table where they all had to call out one of the Faye analogies, and they all laughed at me, but I don't care, it's brilliant. Okay, if the oral-B brush cleans so well subgingivally, does the patient really need to interspace all around the mouth? Well, that goes back to what I was saying earlier. So we have the interspace in there in the plan, but it depends how deep those pockets are. It depends how far the oral-B bristles go. If you get enough resolution, then no, absolutely not. So that's why I wouldn't bring the interspace brush in at first visit. We'd always do the toothbrushing first, get on top of that, get whatever resolution we can from that and from the incidental aids, and then what's left, the interspace brush tends to be site specific, for me anyway. Faye, redo the video. Yeah, we'll do that. Yep, I've answered that. Do you recommend using incidental brushes before or after brushing? Couldn't care less. They need to disrupt that undisturbed biofilm, so I don't have any preference on that at all. Whatever works for the patient is fine by me. Push, don't brush. What about patients who have existing recession? I mean, there are if there's very thin biotype, there are examples, there are situations where we have to severely moderate our brushing technique, but patients who have existing recession because of perio disease have got much bigger fish to fry, and the recession hasn't been caused by the brushing technique. The recession's been caused by the perio. So it makes no difference whether they've got existing recession. If they've got existing recession, the chances are they're probably a perio-susceptible patient and they need it more than anybody else needs it. You need to establish why that recession's there and what caused it. It might be because of poor ortho, it might be their biotype. You've got to assess that, but the technique isn't gonna cause damage. A poor technique's gonna cause trauma. A good technique's not gonna cause trauma. So yeah, I'd be establishing why that recession's there first. How do you manage giving intraoral subgingival brushing instruction if the practice you work at will not allow you to give the patient the brush for free? It's all built into the cost of treatment. So for a perio patient, they know that I'm going to be giving 1 or 2 interspace brushes away. So that's built into the cost of perio treatment with me. We buy these in at next to nothing. They're like £1 or something, aren't they? So we just build it into, when we set our fees, we build it into the cost of that. Lots of people don't do that. Lots of people charge for them, and they get the patient's permission to start with. But again, you know, get the first message right, get them in the right headspace, get them thinking right. Patients aren't going to say no to an extra £1. You just need to get their permission if you're not building it in. The bristles need to go under the gum like a nail brush under your nails. Yep, that's exactly what I said in the video that it sounds like you probably couldn't hear. What's Faye's favourite disclosing product? I like the pre-soaked sponges. So I like the sponges that are pre-soaked with discloser, because there's less plastic waste. You haven't got a Dappens pot, you haven't got a brush, it doesn't splatter anywhere, you just got a little bit more control over it. They're my absolute favourites. Test drive will be an aerosol generator, and we won't be able to do this in the current climate. I disagree. It doesn't generate, or there isn't evidence to suggest that it generates aerosol. it generates splatter, and that's different to an aerosol. I know that Oral-B are working on this and will be releasing a statement on it at some point. But for me, we do have permission to use Profi, to slow speed with a Profi if we dry the area first with a gauze. And for me, it's no different. I love the test drive. I have 2 handles, so I can use one whilst the other is disinfecting. I'm not sure what you're doing with your disinfection. Is that my time up, Sharon? You're waving at me.
It is. Thank you so much, Faye.
Oh, my pleasure. I'm sorry I haven't got through everybody's questions, but you can ask me the questions. You can email me, or you can go on the forum, or whatever, or just get in touch, Messenger, Instagram, whatever it is these days. Feel free. I'm sorry that I haven't been able to answer all those questions.
Brilliant. Thank you ever so much. Thank you everybody else for joining us. Thank you to Oral-B for sponsoring. You'll be redirected to a SurveyMonkey. If you can complete that, we can do your CPD certificate. I'll get those out to you sort of probably by Friday. Have a good evening. Again, thank you to Michaela. Thank you, Faye. Have a good evening.
My pleasure. Stay safe. Good luck, everybody. Bye-bye.